Hi, this is Jean Deschamps
and William Beaubien-Souligny
from the Université de Montréal. This is part of a series of video tutorials and reviews about venous congestion. This video will focus on portal vein assessment. The three other videos of this series will deal with cardiac physiology and hepatic vein assessment, intrarenal Doppler ultrasound, and integration of all venous congestion profiles. At the end of this video, you will be able to understand the basic principles of cardiac pulsatility transmission to the peripheral venous system, understand the correlation between cardiac physiology and portal vein flow, understand the calculation of the pulsatility index, and review confounders and evidence. We will quickly highlight some basic cardiac physiology points relating to the impact on peripheral venous congestion. For the more detailed explanation, we would refer you to the first video of this lecture series called Venous Congestion, Normal Physiology in Hepatic Veins. In general summary, peripheral venous flow changes are intrinsically linked to changes in right heart pressure, specifically the RA. Any changes in cardiac pressures are transmitted distally with some degree of attenuation. The major physiological point to remember is that normal RA filling should be throughout systole and diastole with no reversal except for atrial contraction. The major abnormal physiological concept is that increasing right-sided pressure leads to impaired filling in systole with predominant filling occurring in diastole. This may lead to complete absence of filling during systole, which is reflected in the peripheral venous system. While the hepatic vein tracings directly reflect cardiac pulsatility in the healthy individual, it is not the case in the distal venous system. The venous flow is non-pulsatile as the blood from the capillary system is shielded from any arteriophasic component. If pulsatility occurs, it is thus dependent on backward transmission of the RA pressure variations. This transmission is usually minimal given the high compliance of the venous system, which attenuates the RA pressure variations with increasing distance. The signal is usually monophasic with only slight, if present at all, S and D waves. Conversely, venous compliance decreases as the filling pressures in the venous system and right heart increase, and transmission of RA pressure variations during the cardiac cycle increases. Accordingly, the higher the filling pressure, the more peripherally the changes are transmitted as shown in this figure. This represents the basis of abnormal Doppler findings in the portal, intrarenal, and femoral veins. The portal vein is unique in its isolation from the arterial and venous system, respectively by their splanchnic capillaries and the hepatic sinusoids. This explains the evolution from continuous monophasic to pulsatile flow in the patient with increased right-sided pressures. This differs from other biphasic or triphasic variability in other venous sites. In the healthy subject, there is a continuous flow with minimal variations during the cardiac cycle. Cardiac cycle pressures are transmitted to the portal vein with increasing right-sided pressures.
Next, we will discuss the technical acquisition that forms the basis of portal vein Doppler assessment. The transducer is positioned on the anterior to mid-axillary line to obtain a coronal view of the liver. Generally, this provides a good alignment for pulse wave Doppler. The hepatic vein can usually be sampled from the same location. One important technical consideration is ensuring that there is a recorded ECG tracing on the machine. While less problematic than with hepatic vein Doppler, the ECG ensures the proper identification of cardiac phases. In this image, you can see that the portal vein is aligned near parallel to the ultrasound beam. Once the portal vein is located, pulse wave Doppler ultrasound can be activated to assess the velocity patterns. Notice that the signal shows up as red on color Doppler and is above the baseline on pulse wave Doppler. This indicates that the flow is directed toward the probe. This is the opposite of hepatic vein flow.
Next, we will discuss the interactions between cardiac physiology and portal vein flow patterns. As discussed previously, the venous flow is non-pulsatile as the blood from the capillary system is shielded from any arteriophasic component. If pulsatility occurs, it is thus dependent on backward transmission of RA pressure variations. In the case of the portal vein, The shielding from the venous sinusoids blunts the systemic triphasic signal. The resultant is that the normal portal vein flow generally has fused S and D waves that are frequently hard to distinguish. If there is a slight variation, the systolic flow is usually lower. Normal portal vein flow is thus described as a continuous monophasic flow.
Venous compliance decreases as the filling pressure in the right heart increases. This results in the transmission of right atrial pressure variations during the cardiac cycle to the portal vein. This explains the evolution from the continuous monophasic to pulsatile flow. This differs from the other biphasic or triphasic variability at other venous sites. As illustrated previously, it is not possible to distinguish the systolic and the diastolic waves in the normal patient because they appear fused together. In this case, increasing right heart pressure leads to the reduction or blunting of forward venous return during systole. This translates into a minimal velocity at the end of cardiac systole in the portal vein. The continuous monophasic flow does remain continuous, but with important variations in velocities during the cardiac cycle, which is usually called pulsatile. Please note that there is a slight delay to the peak, maximal, and minimal velocity in relationship to the ECG that may be related to the anatomic position or secondary to technical considerations. This may cause the maximal diastolic and minimal systolic velocities to appear past the atrial systole and into the mid-diastole respectively. Severe right heart pressure elevations can lead to a similar picture as in the hepatic veins. In this situation, there is interruption of forward flow and then reversal during systole. Generally, this is associated to tricuspid regurgitation, but it has been also observed in its absence. The physiopathology is not completely clear, but this may be related to the transmission of pressure through a closed tricuspid valve in a non-compliant and high-pressure right atrium. The pulsatility index or pulsatility fraction is the quantification of the difference between the lower systolic velocity and the higher diastolic velocity. It is calculated using the equation on the screen. As described previously, the normal flow should be continuous and monophasic, usually leading to a pulsatility index of less than 30%. Generally, a pulsatility index equal or above 50% is considered abnormal and warrants consideration for increased heart pressure as the cause.
The portal vein is subject to the impact of surrounding structures, namely the hepatic tissue. Different degrees of disease may impact the portal veins flow in different ways. The impact relating to the different stages of liver disease has not been well documented in the presence of cardiac disease. As such, it can either increase or decrease pulsatility depending on the type and degree of pathology. Some reports do mention that liver steatosis in the absence of fibrosis can reduce portal vein pulsatility significantly. The hepatic artery is in direct communication with the portal vein through the sinusoids and can lead to a systolic spike in some patients. However, an animal study showed that clamping the hepatic artery does not influence the pulsatility index. This may be more significant in patients with arteriovenous malformations. Furthermore, young healthy subjects may have some pulsatility, particularly those with a low BMI. It is not clear if this represents direct contact transmission of aortic pulsations or venous transmission. Similarly, a dilated inferior vena cava is also a reported finding in this population. According to our experience, the hepatic vein waveform is normal in those patients. Arrhythmias may influence venous Doppler profiles. Atrial fibrillation leads to a disappearance of the A wave, but does not appear to significantly impact portal vein pulsatility. However, it is necessary to perform an average pulsatility index on 3 to 5 beats given the variable filling resulting from the irregular beats. Ventricular pacing is associated with a retrograde A wave, a biphasic hepatic vein profile, and an abnormal portal vein and intrarenal Doppler flows. This may reflect the negative effect on cardiac function rather than be a confounding factor. As described previously, one noteworthy point is that there may be an EKG delay due to blunting or technical factors. Intrathoracic pressure changes represent a complex heart-lung interaction. This results in increased right-sided pressures from changes in transmural cardiac pressures and pulmonary resistance. The impact can be significant enough to cause increased pulsatility. However, it likely does not represent a confounder. On the contrary, it may identify patients more at risk of abnormal right-sided pressures under specific conditions. In some cases, this can be inverted, as in this example, where extubation actually worsened the pulsatility. This was because the intrathoracic pressure was impeding some venous return, which was actually favorable to a dysfunctional RV.
Venous pressure variations during the cardiac cycle might not be the only hemodynamic factor influencing portal flow pulsatility. During observational studies, we observed an association with cardiac index. Low cardiac output from worsening left or right cardiac dysfunction can exacerbate pulsatile flow by decreasing mean splanchnic filling pressure. The combination of increased venous pressure variation during the cardiac cycle and decreased mean splanchnic filling pressure may exacerbate pulsatility, leading to a high pulsatility index. As such, the pulsatility index might be a good marker of the overall hemodynamic impact of high venous pressure in different hemodynamic status. A summary of the available evidence showed that increased portal pulsatility is associated with high right atrial pressure and tricuspid regurgitation, with reduced right ventricular systolic function, with abnormal bilirubin and worse prognosis in heart failure, and with increased complications after cardiac surgery, as well as in critically ill patients. However, please note that evidence comes mainly from heart failure and from cardiac surgery patients at the moment. An important limitation of using portal vein Doppler profiles for clinical assessment is that they do not provide information about the patient's position on the Frank starting curve. As such, abnormal findings do not necessarily mean that diuresis is warranted, as some pathologies, such as chronic pulmonary hypertension, are preload dependent. These may be better treated by pulmonary vasodilatation and inotropic support. As seen here, there are only case report evidence for the therapeutic intervention, with both interventions improving the amount of portal flow pulsatility. However, as there were no control group, significant confounders as to whether the intervention is the source of improvement are possible.
Feel free to contact us through our Twitter accounts with any question or comments. We hope you enjoyed this educational video.